Thank you very much. I have no disclosures. Okay, so what we're going to talk about, first of all, is informed consent. What's the idea of it? We're going to discuss some strategies to address patient concerns regarding having residents involved in their care. I'm going to review surgical outcomes with and without resident involvement, and finally talk about failure to rescue and actually the benefits of having residents. So resident education started right here in Baltimore with Halstead, pictured there, and Dr. Osler. It's a system of graded responsibilities and independence. There are really no widely accepted guidelines or policies at all regarding the role of surgical trainees in patient care. And usually, and I know this, I'm sure a lot of the attendings in the room would agree, there is little to no relevant discussion or addressed only by vague statements on the consent when you're talking to patients. So I actually looked at our consent here at Hopkins and found a line that I didn't know was there, and when I showed it to a lot of people, they didn't know it was there either. And basically it says that the patients agree and they understand that their surgeon will be present for the critical portions, that they may be coordinating care for other patients, and they may not be present during the non-critical portions. I don't go over that part with my patients. I don't know if anyone actually ever reads it. So one issue is that patients really may not differentiate among students, interns, residents. They don't know what an attending is. Sometimes they don't even know whether a resident has graduated from medical school, whether they're even doctors at all. Some patients may have a little bit more savvy and kind of had different expectations for their residents based on their position, but most do not. The history of informed consent was really not defined until 1914. Prior to that, there was this kind of paternalistic role of the physician who would basically dictate the treatment to a very obedient patient. After that, really the main key component was identifying the responsible surgeon who was going to perform the procedure. This was pretty straightforward in a non-teaching scenario or private practice, and later the idea of ghost surgery emerged. And this was defined as the practice of allowing someone other than the responsible surgeon to perform the procedure. And this was actually further applied to allowing trainees to operate on patients without specific patient consent. In the late 1970s, this came out in a 60 Minutes episode, which looked at general surgery residency entitled Ghost Surgery. And following that, there were many sensationalized anecdotes with different titles. And you can imagine in the lay press how this played out, looking at what we do on a day-to-day basis and how they kind of reiterated that residents were doing things people didn't know. In 1978, there was, in the state of New York, proposed legislation looking at the role of residents performing surgery, and that they identified there really is a lack of discussion. They thought there should be detailed information regarding the role of trainees and that this should be part of the informed consent process. However, attending surgeons countered that the informed consent really, again, only needed to include the responsible surgeon, and this was defeated. And again, most surgeons do not volunteer training information without being specifically asked. So what are our trainees doing? These are our Hopkins residents here. They're really not getting any formal training, and they're not volunteering information to patients either. Most residents learn from others. They watch their senior residents. And there was one study at Temple University where the residents actually had a curriculum on how to do informed consent. They used standardized patients, they did role play, they had risk management come. Most places do not have that. We're transitioning more and more to this idea of patient-centered care, and that we need transparency. And how are we going to do that? There were several studies of the general public asking them about having residents involved with their care. Most of all, people thought that was a great idea, 96%. However, once they started getting into it a little bit more detail, if they said that residents were going to be involved with their surgical procedures, the agreement decreased. And then when asked if residents should participate in complex procedures, this decreased even more. And this is showing how the idea, if a junior resident is assisting the surgeon, how most patients, just over half, would agree with that, and how low it is if they're given the option of having the resident performing the procedure. There was another study that looked at whether they could educate the public. And they had an informational pamphlet. They described each resident, what their roles were, what their education was, and what their responsibilities were in the team. And they found that this definitely increased patient willingness to have a chief resident operate independently. They found that patients were still considering the level of the resident and the complexity of the procedure, however, when they were going to decide whether to give consent. There was a study looking at the bariatric surgery population, and again, this is usually done in academic centers, although not always. Again, most patients express support for being done at a teaching hospital. This dropped a little bit down, thinking about a surgeon operating with a resident just observing. When they asked whether they would consent to the surgeon observing or having just the resident even assisting, this dropped even lower. These are the numbers when they looked at whether the patients were comfortable with a resident. On the left is a resident just assisting. So to have an intern assisting in the operating room, only 44% felt comfortable with that. On the right, when you look at whether they felt comfortable with the staff observing a resident operating or even not even in the room, you can see it's just over 10%. So when they asked patients about their view of residents assisting, most said that they expected to be asked permission. There was another study that looked at community teaching hospitals and academic centers in Massachusetts. Overwhelmingly, just under half reported that they got patients' concerns about trainee involvement, a little bit more at the community centers. And most were able to negotiate with the patients to allow the trainees to be involved. The arguments that they would use, there's usually, we need an extra set of hands, just the practicality of needing a resident. The ethical need that we need to train these future surgeons because they're going to be the ones taking care in the future. And then they would bring up this idea of improved quality of care. The patients communicated that this needed to come from the attending, it needed to come early before the operation. However, they found that over a third would alter how they performed surgery to the patient's request. This was to have the trainee only assist, maybe hold a retractor or hold the camera, and about 10% even would not have the trainee scrub at all. This raises concerns about changing your practice due to a patient's request from your usual technique and the risks of that as a surgeon. So the big thing about quality of your care, a lot of patients will ask, will my outcome be different if there's a resident involved? And there have been multiple studies that found that resident involvement does not affect outcome. So there's a lot of small-scale studies, general surgery, trauma, kind of looking at outcomes. And then there have been several NSQIP database studies looking with large populations, specifically at outcomes with and without residents. In 2012, there was a study of outcomes. They found only a small increase in superficial wound infections, and that was thought to be from the increase also in operative times, as we already heard about. Mortality and any major morbidities were similar. However, they commented that this still is based on graded responsibility and skill level and complexity. In 2016, this was a larger study. The previous one was about 40,000 patients with residents and 20,000 without. This was a large study, and their hypothesis was that with the new duty hour limits and teaching paradigms, would residents still be able to care for the sickest patients? They used matching. They had, as you can see, over 260,000 patients, which they matched and came up with over 83,000 pairs with and without residents involved in their care. Their outcomes were operative mortality, composite morbidity, and failure to rescue. So failure to rescue is defined as this postoperative mortality that follows development after a perioperative complications. There's basically 7 main groups of these complications that could lead to death. And this failure to rescue rate is thought to represent hospital as well as provider quality. And in the study, they were suspecting that the FTR could be used as an indicator of whether residents were affecting either positively or negatively the FTR. What they found was, again, just like we've heard, increased resource use, OR time, sometimes length of stay. There was a slight increase in morbidity. However, they found that there were significantly improved FTR rates with no change in overall mortality. This is showing those FTR rates with the attending only versus having a resident involved. Basically, the bottom line was they found there were some slight increased costs associated with resident involvement because of the length of stay and resource use. However, by improving the FTR rates, they ultimately improved overall survival. So in conclusion, our future depends on the ability to develop well-trained surgeons. If there's going to be any change to the informed consent to include details about resident involvement, we need to consider how that's going to impact our residency training. Formal patient education on the importance and role of the trainees may ameliorate their unwillingness to have residents participate, and that we can demonstrate that residents provide benefit to patients. Thank you.